Thank you. I would like to thank the organizing committee at ISMPO and MSD for having me on board. It's an absolute honor to be a part of the national conference of ISMPO, which is being held on a virtual platform. So, over the next 30 odd minutes, what I would be doing would be speaking about the role of immunotherapy in management of recurrent metastatic head and neck squamous cell carcinomas. The next 30 minutes would be divided into three parts. The first part, I would be speaking about why India faces a unique problem of head and neck malignancies. How is the scene different in India compared to rest of the world? In the next part, I would talk about the evolution of immunotherapies in the management of advanced head and neck squamous cell carcinomas. And the last part, I would briefly talk about how to sequence given the explosion of new molecules in this arena. So, so basically, India has a unique problem with head and neck squamous cell cancers, and this is why it's unique. This is the data from Globocon 2020, which says that nearly 10% of the cancers in India are in the lip and the oral cavity region, and nowhere in the other world, in the rest of the advanced world, would we see such a high proportion of lip and oral cavity cancers. And in terms of absolute number, this is nearly 135,000 in the year 2020. So that just denotes the magnitude of the problem. And if we look at projections for the year 2025, we know that total number of tongue cancers would probably exceed 60,000 per year. Total number of mouth cancers would exceed 80,000 per year, 90,000 per year. Hypopharyngeal cancers, another 20,000. Laryngeal cancer, another 35,000. So all of this put together, that makes up a significant number of head and neck squamous cell cancer patients. And the other significant difference compared to our own population as compared to the Western data is that a vast majority of our patients have loco-regional disease, unlike in the West where the majority is the localized disease. In our patients, only about a fourth, which is about 27% of our patients, present with just localized disease. And the management of localized disease is very different from loco-regional disease, and we need to tailor make management protocols and principles for our own population. So when we look at the relative proportion and clinical extent of the disease at the time of diagnosis, across the board, across all sites in the head and neck region, be it the oropharynx, be it the hypopharynx, nearly 70% of the patients present in a locally advanced stage, and which makes the management that much more challenging, and unfortunately the outcomes that much poorer. So if we look at the type of treatment according to the extent of disease, in India, if somebody has got distant metastasis of head and neck squamous cell carcinomas, only about 15% receive pure thoroughbred systemic therapy. Wherever relevant radiotherapy is added, that's added in about 35% of the patients. But I think the staggering number over here is that only 15% have systemic therapies, even though they have stage 4 disease, and which is slightly surprising. But another good surprise for us is that given the fact that our own oncologists are very well tuned to management of head and neck squamous cell carcinomas, about at least half of them get some sort of a multi-modality treatment, which means that all the relevant stakeholders in the management of this very difficult to treat malignancy are involved whenever we have a patient with metastatic head and neck squamous cell carcinoma. So this is basically a clinical practice guideline which was issued by all of our doyens of medical oncology in India and our current office bearers of ISMPO, and this was published in Indian Journal of Cancer. So as per this, if a patient has metastatic disease at presentation, and if they had some sort of a chemotherapy received prior, or if this was a second primary with a prior radiation, in that scenario, a valid therapeutic option would be a single agent immunotherapy, and this could be either pembrolizumab or nivolumab. However, if a patient did present with distant metastasis at presentation, then the recommended first line option would be a combination of pembrolizumab with chemotherapy with a multimodality approach factored in wherever it is relevant. When we talk about the NCCN 2021 guidelines, and this talks about the recurrent, unresectable, or the metastatic head and neck squamous cell carcinomas, first line therapy is the use of pembrolizumab with a platinum based chemotherapy background. So this is another thing that I need to emphasize, that when we are trying to pick immunotherapy in our first line treatment regimen, the backbone chemotherapy has to be either cisplatin or carboplatin along with 5-FU, because this is the one which has got category 1 recommendation. If the tumors express PDL1 with a CPS score of more than 1, or if it's CPS score more than 20, then category 1 recommendation would probably be a single agent pembrolizumab. However, if you're talking about subsequent line therapies and if immunotherapy has not been received in first line, then nivolumab itself has a category 1 recommendation, and so does pembrolizumab. So how did this evolve? How did immunotherapy evolve in the management of head and neck cancers? And all of this can be traced to the role of PDL1 testing in head and neck cancer. So PDL1 can be expressed by multiple cell types in tumors. So PD1 is mainly expressed on lymphocytes such as T cells, B cells, and NK cells. PDL1 can be expressed on many cell types that make up the tumor microenvironment, and PDL2 expression is more frequently restricted to the antigen presenting cells only. So when we use the antibody clone of 22C3 FARM-DX to do our PDL1 testing, and this is done by the immunohistochemistry method, one of the two scoring methods can be used. One of them is called as the tumor proportion score, and another one is called as a combined proportion score. So what is the difference? So PDL1 expression is assessed differently depending on whether the immune cells meaningfully contribute predictive value in clinical validation for specific tumors, or whether we take a combination of the tumor and the immune cells. So TPS score counts only the PDL1 staining tumor cells, whereas a combined positive score, which is the CPS score, it takes into account the PDL1 staining of not just the tumor cells, the lymphocytes and the macrophages, with the denominator of all the total viable tumor cells. So TPS is actually relevant for predicting the response of pembrolizumab in non-squamous cell lung cancer, while the combined positivity score is relevant for predicting the pembro response in several non-small cell tumor types. So if it is lung, it is TPS. If it is a non-lung, then it is CPS. So that is probably a simpler way of trying to remember things for us clinicians. So why is PDL1 testing different? TPS for lung cancer and CPS for other tumor types. The one of the earliest keynote trials, the keynote 001 trial, this looked at the predictive value of PDL1 in non-small cell lung cancer was contributed by only tumor cells but not by the immune cells. So PDL1 expression on immune cells did not improve the predictive value in non-small cell lung cancer, and this can be seen by the ROC analysis curves over here. Incorporation of immune cells unfortunately increased the false positive rates and did not improve the true positive rate. So very early in the game, it was established that TPS was the way forward when we are trying to assess as a biomarker for pembrolizumab treatment in non-small cell lung cancers. But when we looked at the data from Keynote 012 and the Keynote 055 trial, and this looked at the comparison between the CPS and TPS scoring, the combined positivity score demonstrated a higher sensitivity than tumor positivity score, and this captured more responders. So essentially, TPS demonstrated a higher specificity than CPS, but this also includes more non-responders. So you can see the difference between the sensitivity and the higher specificity between CPS and the TPS scorings. So CPS is sensitive than TPS at lower cutoffs, and this was derived from the data of Keynote 040 trial. There are multiple layers of evidence for selecting the PDL1 CPS scoring in head and squamous cell cancer. So if we want to know why we are taking CPS as the biomarker and not TPS as the biomarker for IO use, the data comes across from trials like the Keynote 012, Keynote 040, and Keynote 048. I mean, this is some very interesting data which was, I think, presented in ESMO 2018. This was a small study which basically looked at the various antibody clones available. So in head and neck squamous cell carcinoma, the SP263 clone, the 22C3 clone, the 28A clone, and the SP142 clone were assessed across different patient populations. So when using the same cutoffs applied to each assay, 22C3 and 28A showed greatest concordance for with 263 for TC, IC, and CPS, although SP263 consistently identified a higher proportion of patients as PDL1 high across cutoffs. So this data indicates the algorithms for PD1 evaluation select different populations and they are not interchangeable. So this is the first point which I need to make. So first take home message from us today is that if we are trying to find a biomarker to predict the use of IO in first line in metastatic head and squamous cell carcinomas, the antibody clone to be used is the DARCO22C3 and definitely not any of the other clones. This slide talks about the evaluation of Pdl1 IHC expression, and this is a study from a tertiary referral center in India. And this was presented in about March 2021, March last year. So in the study, of the total 100 cases which were evaluated for PDL1 expression on the 22C3 DARCO antibody clone, the overall PDL1 positivity rate was about 84%. Was 84%, with 38% showing a low PDL1 score of and 61.9% showing a high PDL1 score. So the significant takeaway from here is that if we look at the rates of PDL1 more than or equal, CPS score more than or equal to 1, that was about 80% in this study from our own patient setting. And of this 80%, about 60% actually had a PDL1 scoring of more than 20, which means if we start testing all of our patients for CPS scoring on this particular antibody clone, the pickup rates are in excess of 60%. So the key takeaways are that PDL1 is expressed by multiple cell types and is a ligand for the PD1 receptor, supporting the biological rationale of PDL1 as a predictive biomarker in patients who may receive anti-PD1 therapy. Based on comparative analysis of TPS versus CPS as a predictor of efficacy in early squamous cell carcinoma trials, CPS was determined to be the more appropriate scoring method for pembrolizumab in head and neck squamous cell carcinomas. The appropriate CPS cut point for HNSCC was determined based on the ROC curve sensitivity specificity analysis, leading to the clinical validation of CPS as a predictive biomarker in Keynote 048 trial. The different PDL1 assays are specifically co-developed with their respective therapeutic agents and should not be used interchangeably without prospective validation in a clinical trial setting. So maybe in lung, it may be okay to try and interchange, but when we are talking purely about head and neck cancers, it is not such a great idea to interchange the antibody clones. The next part of my talk would be about the pivotal Keynote 048 trial. This was a phase 3 study of first-line pembrolizumab for recurrent metastatic head and neck squamous cell carcinomas. So the rationale behind the study was PD1 inhibitors like pembrolizumab and nivolumab were approved for second-line treatment. Higher PDL1 expression is associated with the improved response to pembrolizumab, and chemo is a rational combination partner for PD1 therapy, anti-PD1 therapy. That's because we know that chemo disrupts the tumor architecture and may overcome immune exclusion also. So the results in antigen shedding, and it induces a rapid disease control and response to immunotherapy. So from this IHC pics, you can see that before chemotherapy there was no tumor architecture disruption, but once chemo was given, there was tumor architecture disruption, and this disruption sort of sensitized the tumor to the effect of immunotherapy. So this was a straightforward comparison. This trial had a schema of 1:1 randomization between 3 arms. One arm was pembrolizumab as a monotherapy for up to 35 cycles. The next arm was pembro with cisplatin or carboplatin plus 5-FU as the backbone. The chemo was given for 6 cycles, and this was subsequently followed by pembrolizumab as a maintenance therapy. And then finally there was the standard of care comparator, which was the extreme trial, and the extreme protocol, which was a combination of cetuximab with carbo or cisplatin and 5-FU followed by cetuximab maintenance. The key eligibility criteria was that patient should have had an incurable disease, ECOG TS 0 or 1. The patient should have had a known P16 status, and this covered the whole gamut of our tumors in terms of oropharynx, oral cavity, hypopharynx, and larynx. So the study endpoints were so that the primary study endpoint was the measurement of overall survival and progression-free survival in a patient expressing CPS score of more than or equal to 20 and a CPS score of more than or equal to 1, and in the total population. So one of the big understandings from this trial schema that we can take is that only when somebody is very confident of getting a positive result would we use overall survival as a primary endpoint in a metastatic trial. Otherwise, we know that most of the older metastatic trials use PFS or a QL as the primary endpoint, and OS was more often the secondary endpoint. So the authors were fairly certain that IO would be a very rational and effective combination even in first line, and that's why OS was picked as a primary endpoint. The secondary endpoints looked at the overall response rates and the QL data. There was a key exploratory endpoint, which was the duration of response in both the CPS more than 20 and the CPS more than 1 population. So because this was a 3-arm trial, there were a lot of statistical considerations which entered into the picture, and the second interim analysis was performed per protocol 17 months after the last patient was enrolled. And these are sort of the patient numbers in all of the trials. This was a huge trial which randomized nearly 900 patients, which means that nearly 300 patients went into each of the treatment arms. So when we look at the baseline characteristics, the one area where I want us to pay attention to is that, the CPS more than 20 population in the pembro monotherapy arm was about 45%. In the extreme arm was about 40%. When we looked at the pembro chemo arm and in the extreme arm, again it was about 40%. Whereas initially in one of my slides I did present from the Indian data that probably our patient population has a higher possibility of expressing a CPS score of more than 20, which was nearly 60%. So here it's about 40%, but in India that might be even go higher up to about 60%. When we looked at CPS scores of more than 1, if we take that as PDL1 positive, across the board, about 85% of the patients qualified for this, which means that the takeaway from this is that head and neck squamous cell carcinoma patients do tend to have in a vast majority PDL1 positivity status. So first, let us talk about the pembrolizumab monotherapy arm in comparison with the cetuximab chemo combination. So when we looked at the monotherapy pembrolizumab arm, and these are the PFS curves, the one on the right is for the CPS more than 20 subset, the one on the left is for the CPS more than 1 subset. In this, we could see that there was no statistical difference in the progression-free survival between the pembro monotherapy arm versus the cetuximab arm. The same went for the CPS more than 1 subset of patients. Again, there was no statistically significant PFS benefit. However, when we look at the overall survival, here is where things start getting interesting. When we compared pembrolizumab monotherapy versus patients who went on the cetuximab plus chemotherapy arm, at 24 months, nearly 25% of the patients were alive. At the same time, when we looked at the cetuximab chemotherapy arm, about 20% of the patients were alive. So the OS hazards for pembro monotherapy arm was about 0.81, and the median overall survival in the pembro mono arm was about 11.5 months, whereas the cetuximab chemo arm had a median OS of about 10.7 months. And we need to understand another thing over here. When we talk about Indian patients, they do present to us with far worse performance status. Many of them have advanced disease, which would have contributed to their performance status dipping significantly, and the tolerability of these patients when we try and introduce chemotherapy in the first line would have been far less. So many a times, if we don't know if our patient is eligible for chemotherapy, and if the patient does have a CPS score of more than 20, then we know that pembrolizumab monotherapy is going to make a significant difference. Especially when we talk about the CPS more than 20 setting, we can see that at about 2 year mark, 35% of the patients who were on pembro monotherapy were alive. And even more surprisingly, 20% of the patients with metastatic head and neck squamous cell carcinoma were alive at the 4-year mark if they did end up having a initial response to pembrolizumab, and if they had a CPS score of more than 20. When we looked at the CPS more than 1, again there was statistically significant improvement in overall survival in the pembrolizumab arm as compared to the cetuximab chemo arm. And this is a very interesting curve. This looks actually at the duration of response. So if we are able to pick up the patients who respond to pembrolizumab, then the duration of response is very, very significant. The median duration of response in the responders, pembro responders, is at least about 2 years. So imagine, telling a patient who walks into the clinic tomorrow that yes, your CPS is more than 20, and if we are able to prove a response for you, you would more likely continue to respond for about 2 years, and this is in a metastatic setting. So this definitely did revolutionize the management of metastatic squamous cell carcinomas in the head and neck area. And you can see over here the data of CPS more than 20. The median duration of response was about 2 years. Same with CPS more than 1. So the key over here is that for us, we need to identify who are going to be these responders. And once we know that a patient is responding, it is very likely that they would respond for at least about 2 years. So this slide talks about the treatment-related adverse events. The adverse events were, obviously, when we looked at the pembro mono arm, the adverse events were significantly lesser as compared to the cetuximab chemotherapy arm. Obviously, cetuximab chemo did not have any immune-mediated adverse events, but the pembro mono arm also did not have too many significant immune-mediated adverse events. So the treatment discontinuation due to immune-mediated adverse events and immune reactions was only about 2.3%. The next couple of slides I would talk about the comparison between the pembro chemo arm versus the cetux chemo arm. And in this, obviously, the PFS data did not show any statistically significant difference between either of the arms. However, when we talk about the OS in the pembro chemo arm, this demonstrated a statistically significant better median overall survival of about 13 months as compared to 10.7 months in the cetux chemo arm. When we look at the comparison between the CPS more than 20 and CPS more than 1 setting across both of these subgroups, we know that the pembro chemo combination had a better median overall survival as compared to the cetuximab chemotherapy combination. Again, if we look at the median duration of response in the pembro chemo versus the cetux chemo arm, if a patient had a CPS of more than 20, there was a much better duration of response as compared to the cetuximab chemotherapy arm. Obviously, the treatment-related adverse events would be a little bit more when we talk about the pembro chemo arm versus the cetuximab chemotherapy arm. Immune-mediated adverse events were also there, but again, the treatment discontinuation rate was less than 3%, which means that in the bigger picture, it does not make too much of a difference. So adding chemotherapy to immunotherapy in the first line did not result in too much of a disruption to treatment, and it was fairly well tolerated. So to summarize the safety data over here, the long-term follow-up confirms statistically significant improvement in overall survival for pembrolizumab versus cetuximab chemo in the Pdl1 CPS score more than 20 setting and in the CPS more than 1 populations. Pembro chemo versus cetux chemo arm in the Pdl1 more than 20 and more than 1 setting also showed a improvement in median overall survival. The duration of response was also better as compared to the cetux chemo arm, and safety was also favorable to pembrolizumab versus the cetux chemo arm and comparable for pembro chemo versus cetux chemo arm. The last couple of slides would be about how to sequence is, given the fact that we have had cetuximab for a fair bit of time and many of us are comfortable using this, and we know that we can predict responses when we put our metastatic patients on cetux chemo. So this was like an exploratory analysis which looked at the progression after the next line of therapy following pembrolizumab or pembro plus chemo versus the extreme as a first line therapy in metastatic HNSCC patients. So this basically looked at the PFS2, and PFS2 was calculated as the time from randomization to objective tumor response on next line therapy or death from any cause. So this was the exploratory outcome which was assessed, and if we look at the PFS2 curves over here, in the pembro mono versus cetux chemo arm with the CPS more than 20 population, the 12-month PFS2 was about 50% and the 2-year PFS2 was about 25%. So which means that even in terms of PFS2, the second PFS, patients who had a CPS of more than 20 and received pembro in the first line and an anti-EGFR in the second line, they demonstrated a better PFS2 as compared to reversing the sequence over here. So the same was the case even in CPS more than one population. There was a statistically significant significant PFS2 benefit with the hazard of 0.8 over here. Okay, so for the want of time, I'm skipping a few slides, but this is a table which I want us to sort of pay some attention to. In this, we can see that if patient received pembro monotherapy in the first line, a significant proportion of them ended up receiving some kind of a EGFR in the second line. And if we look at the reverse, if somebody received an anti-EGFR like cetuximab in the first line, they did about 50% of the patients ended up receiving an immune checkpoint inhibitor in the second line. So which means that if we are trying to look at the answering the question of how to sequence our patients, the summary of the PFS2 said that pembro monotherapy versus cetux chemo, PFS2 was longer in the arm of pembrolizumab in patients with PDL1 CPS score more than 20 and CPS score more than 1. When we looked at the pembro plus chemo versus the cetux chemo combination, PFS2 was again longer for pembro chemo arm in patients with PDL1 CPS more than 20 and CPS more than 1 and in the total population. So the PFS2 data further supports the use of pembro and pembro plus chemotherapy as first-line treatment for recurrent metastatic head and squamous cell carcinoma patients. To summarize and conclude my talk over here, pembrolizumab significantly improved overall survival versus cetuximab plus chemotherapy in the PDL1 CPS score more than 20 setting. The hazard ratios here were extremely significant at a hazard of about 0.61. When we looked at the CPS more than one population, again, this showed a significant hazard ratio of about 0.78. Very importantly, there was no PFS benefit, although pembrolizumab had a lower overall response rates. If a patient did achieve response, they were substantially more durable. Pembrolizumab had a favorable safety profile versus when we compared this versus cetuximab with cisplatin 5-FU. There were lower incidences of all grade of adverse events, lower incidence of treatment-related adverse events leading to discontinuation, and the safety profiles were as expected. So this data supports the use of pembrolizumab monotherapy as a new first-line standard of care for patients with recurrent metastatic head and squamous cell carcinoma that have a PDL1 positive expression. I like to conclude my talk over here, and I'm happy to take any questions. Thank you.